Welcome to the STARS program, seniors taking active roles in society. And now, here's your host, ANITA FINLEY.
Whew, we got to take a deep breath. This has been quite a morning. We've had the most fantastic guests, as usual. But I have someone today who is quite brilliant. I have to tell you, I hadn't met her until, actually, I was reading her articles. Dr. Starkman is with MCA, and she has, what I like is you've chosen something in rheumatology, which is, people don't know they have it. I don't know. They just are in pain and they don't know what they really have, do they?
Not often, no.
Let's get you closer to the mic, and so we get you louder here.
Okay.
Okay, and so the fact that you're with I know Dr. Janke, and I know he very much, and he, of course, started all this, but MCA is a wonderful, wonderful group. Why don't you tell us a little bit about them and what you do there?
Medical Center affiliates has been around for a long time. We have 10 medical offices in 2 counties, and it goes from all the way up in West Palm Beach down to Broward County. We have many practitioners. I don't know how many we are now.
I had one on already. I forget, Dr. Zamale. I don't remember his name.
Dr. Hernandez. We have Dr. Barry.
Shorter name, but that's okay.
Yeah. A lot of them have long names.
Right.
My name's short, and Dr. Barry's.
But
But a lot of lady doctors in the practice, some nurse practitioners, wonderful management. I'm so very lucky to be part of that practice.
Yeah, and they think a lot of you, and that's why they ask that you come on and that you'll be reading her article. For those of you that got your November Boomer Times on page 13, you'll see Dr. Hope Starkman, and she's writing about the modern day treatment of rheumatoid arthritis. So tell us about rheumatoid arthritis.
Okay. Well, before I talk about rheumatoid arthritis, because people will come to me very frequently telling me they think they have rheumatoid arthritis, self-diagnosis. Also, not only that, but they've seen other practitioners who are maybe general practitioners. And I think a lot of different forms of arthritis are just called rheumatoid or osteo. So I think it's really important to distinguish between those two especially. There's over 100 different kinds of arthritis forms, but if you break down arthritis into 2 major groups, you've got the degenerative arthritis, which is essentially osteodegenerative arthritis. It's the wear and tear form. I tell patients if they have, say, osteoarthritis of the knee, say you have 2 pieces of metal and there's a gasket or a piece of rubber in between. That gasket gets worn over time due to trauma, due to age, due to repetitive motion, repetitive injury. So the bone kind of gets closer to the bone, and that causes pain and inflammation. Sometimes it's mostly a degenerative condition.
Is that when they need knee replacements? Well,
there's a lot of things that can be done prior to a knee replacement. There's topical, oral anti-inflammatories, analgesics, injections, cortisone injections, visco supplementation, which is kind of a lubricant that they can inject into the joint, usually the knee, 3 to 5 times. But that's a wear and tear process. It happens to most of us as we get older. That's as opposed to the other general category of arthritis, which is the inflammatory forms of arthritis, of which rheumatoid arthritis is probably the most common inflammatory arthritis.
Then let me ask you a question, Dr. Starkman, that when I've seen people with their hands kind of crippled, I always thought that was rheumatoid.
Well, it can be, but there can be other forms of arthritis that cause deformities, permanent deformities. So I wrote about the modern day treatment of rheumatoid arthritis. Rheumatoid arthritis is one of many inflammatory forms. You have psoriatic arthritis, the arthritis associated with psoriasis, ankylosing spondylitis. Gout is an inflammatory arthritis. These are different in that they are not so much wear and tear. They're really inflammatory. They're related to chemicals that accumulate in the joints, and those chemicals kind of recruit more inflammatory cells, which produce more chemicals. So it's a big cascade of event that needs to be broken. And the earlier you break that cascade, the quicker you can get results. because if you don't treat that, you end up with these permanent deformities, the gnarled hands that you see over time. So we have so many choices nowadays to treat that inflammatory arthritis of rheumatoid arthritis.
Is it possible that you can use supplements or certain kinds of a diet to help?
Some people think that you can use diet. I think that's that's very dependent on the person. Some people are just like different people respond to different blood pressure medications. Different people respond to maybe dietary changes. There's certain foods called nightshades that people feel cause inflammation. My education isn't in that area, although I do acupuncture for some of my patients.
You do
acupuncture, yes.
Well,
I took some training down at University of Miami.
Isn't that interesting that you did that?
Because there are so many patients that cannot take all these medications that I write about, don't want to take it, can't tolerate it, have too many other medical problems. So I like to offer alternatives. But I'm not trained in nutrition, so I don't want to
No, I understand that because you can always get a nutritionist. But I'm thinking about the art. So you then like to use other forms of. It isn't just having the medication. There are other things. So
yes,
that's
behavioral is probably the most important because people with any kind of arthritis, need to often modify their lifestyle. Weight loss is really important for people who have arthritis in their spine and their knees, their ankles, their feet. The more weight, the more pressure there is on the joints every day from the minute you get up and walk, right? So
we don't tend to think about that. But as one ages, is it definite that they're going to get any of the arthritic problems?
Nothing's ever definite. Mm-hmm. Can we do anything to prevent it? We can keep a healthy diet, get enough sleep. We can exercise. I think exercise is very, very important, at least 2-3 times a week. I tell my patients who are pretty sedentary to get up and do something more than they're already doing, especially if they're overweight, because anything more than they're already doing will burn some of those calories and help. And plus, it's good mentally to get up, especially in the morning. I think the morning is the best time to exercise.
But you mentioned about having more sleep. Talk about that.
Oh, we don't get enough sleep, that's for sure. My senior patients, which is a majority of my patients, maybe they sleep 4 or 5 hours a night. Oh, I guess that's okay if they wake up and they feel restored. But most
they
of
may
them
sleep
are
during
tired.
the day too. They take a lot of naps. Would that make up for it?
Some of them do. It can, but I don't think there's a substitute for consecutive hours of sleep. But in any case, so the treatment of rheumatoid arthritis is what you're interested in.
Yes, I am.
So every patient's different. Every patient has other medical conditions or not. They take other medications. They have preferences. They speak to their friends where they live, and they have strong feelings against certain medications before they even take it. You've got to, as the physician, you really got to sit down and listen to your patients. Very important to listen, the history taking. So for rheumatoid arthritis as opposed to osteo, for rheumatoid, there are certain criteria. Not everyone that has arthritis has rheumatoid. There's criteria that have to be met in order to make that diagnosis. Those criteria have to be ongoing for 6 weeks. So someone who's got pain in their knee and their ankle and their wrist, even though I can see them after 2 weeks of that and know pretty much in my heart that they have rheumatoid arthritis, it has to be going on. There's criteria. It has to be going on for 6 weeks. They have to have hand-wrist involvement, morning stiffness, lasting 30 to 60 minutes or more. Usually patients with rheumatoid or any type of inflammatory arthritis have post-rest stiffness. We call it the morning gel, but it doesn't have to be in the morning. Mm-hmm. So anytime they rest and they get up, they're stiff. And that's the hallmark of inflammatory arthritis, as opposed to degenerative arthritis, where they tend to get worse, more pain, more stiff toward the end of the day with use. Rheumatoid and inflammatory, they're worse in the beginning of the day and after rest. Difference, right?
Interesting. That's a
very part of that history taking. Important part.
And so when someone gets up, if they have if they feel, pain or they feel uncomfortable, they could have then the rheumatoid rather than the other one at night.
Yes.
Isn't that
does make a difference.
So this is part of your consultation when you're talking with them, right?
Yes.
What if they have it both times?
Well, people do,
They do,
because
right?
people have multiple forms of arthritis as well. If you have rheumatoid arthritis long enough, eventually you can develop degenerative arthritis. Degenerative arthritis tends to occur in joints that have been traumatized before more often as well. So most patients have more than one form of arthritis.
Did you have to have special training in this field because you've chosen it more than just as a general practitioner?
Yes, yeah. It's another 2 to 3 years after your internal medicine training. But I learned most of my rheumatology from my patients. Training is a couple of years. Practice is your whole career, right? So you're always learning, and every day I learn from my patients. Still, after 24 years of practicing.
You're very young. 24 years. You did this when you were a young woman. Really?
No.
Well, you look good.
Thank you. It's teaching spinning that keeps me looking young, and having small children.
Teach spinning.
Yes.
How fantastic.
It's fun.
Yeah, it is. And you have small children.
Yes.
But you absolutely love what you do. I've been told that by other people there at MCA. I just want everyone to know, if you would like more information. Now, which MCA are you located at?
I'm in Delray Beach 2 days a week, and I go to the Boca office of the practice, which is on Palmetto Park Road near Jog, 1 day a month, mostly to recruit new patients there. And then 3 days a week, I have a private practice in Boynton Beach as well.
Okay.
So I'm pretty busy.
So if someone wants to see you, I don't have the phone number for the Boca office.
Well, rather than, I'll just give you I'll give you general locations because no one's going to remember numbers or addresses. So the Delray office for Medical Center affiliates is west of Jog Road on Atlantic Avenue past Kings Point. There's a Publix in that. It's the Oriole shopping center.
Oh, the Oriole shopping center.
Yes, I think that's easy to remember.
Yes, it is.
Than a number. And then the Boca office is on Jog, near Palmetto Park Road, near the Einstein Brothers bagel shop. Not that I'm advertising anyone specifically, but they do have good bagels.
Yeah. But that's a good thing, though. So, but we are talking about MCA, and that stands for Medical Center affiliates.
Yes.
And they do have open house, and that's really nice to go to. And let me just tell you about that. I don't know if you're ever at the open houses.
Yes, I am.
Which one would you be? The Point Siena, Palm Springs, or West Palm Beach?
No, generally the Boynton Beach.
Boynton Beach.
I mean, not Boynton Beach. I'm fixed on Boynton Beach.
It's okay, I know.
The Delray Beach, I could be at Boynton, and the Delray Beach and maybe the Boca Raton, but mostly the Delray Beach.
Right. So let's do this. I'm going to give everyone one phone number, and then you can call, because I don't have their Boca number. Let me just give you one in, let's go to the Lake Worth, and I'm going to give you that phone number, and you could always call them for more information, because it's a little bit, otherwise it's a little confusing too, and I appreciate that, but it's actually, you know what I'm going to do? I have an 888 number. That's better. You can become an MCA patient or find out about everything else, and that's 888-622-1225. 888. Remember, this is Pencil Talk Radio. Get your pencils out. It's 888-622-1225. Or let me give you their website, which is medcenterinc.com. medcenterinc.com. If you go to some of these open houses, you can enter for a chance to win a $25 gift card, which is very nice. But then you're going to get to meet, you want to make sure that Dr. Starkman is at one of these places you go so you can get to meet her. And she's really very, very smart, especially about arthritis. All right. So now you figured out someone has arthritis.
Okay.
Now, what are you going to do next?
Okay, well, like I said earlier, every patient's different. But you can get 10 patients who I've diagnosed with rheumatoid arthritis, and each one's going to get a different treatment. So say it's a newly diagnosed patient that I just determined has this diagnosis by x-rays, which may show permanent changes like erosions, little bites out of the bone that become permanent changes, bone loss. There's certain criteria that we look for in x-rays. Or they have a positive blood test, rheumatoid factor, or CCP antibody, a high SED rate, post-rest stiffness, bilateral, both side, hand and wrist involvement, and typical changes that I'm used to looking at when I see a patient with rheumatoid. So I've made the diagnosis, and often the patients have already self-treated or their primary doctors have given them an anti-inflammatory, and they're seeing me because that has not worked. Or it works a little, or they take some Aleve over the counter and they get some gastrointestinal symptoms, or worse, they have a bleed and end up in the intensive care, which, it does happen because patients treat themselves frequently. Nobody likes to go to the doctor, let's face it, for a lot of reasons.
So you're saying
some of my patients like coming.
So you're
social.
saying that some people who take Aleve on a regular basis to keep the pain down, also there can be other results.
Yes, yeah. Self-treatment could be a big problem. So they come to me and maybe they've tried some of the basic treatment, or maybe even Tylenol, and I examine them and I find out that they have active disease, they're stiff for hours, they can't open bottles, they may even have fever, dry eyes, dry mouth as a secondary consequence. Lots of different systemic consequences, not only of the joints, but they can have lung issues related to their arthritis, kidney issues, believe it or not, from rheumatoid arthritis, all kinds of other outside complications. So I look at the patient, I look at their history, I look at what they're taking, what they can't take. And very often after the anti-inflammatories, the thing that works quickest and patients don't like taking it is some steroids, prednisone or Medrol, which has a lot of long-term side effects. But the benefit of the steroids is that steroids work pretty quickly. So if I give you a shot today, you're going to be better by tonight, or maybe tomorrow if you take some pills of steroids. But again, the long-term complications of that treatment are many: waking, glaucoma, cataracts, diabetes, bruising, necrosis of the bone, osteoporosis, so many. So we try to keep the steroids limited to lower doses when possible and for short times, because once you start those, it's very hard to stop them. Then there's medication like Plaquenil Hydroxychloroquine, which is unique. There's no substitute for it. It's an anti-malarial antibiotic used to treat milder forms of rheumatoid arthritis, lupus, Sjogren's syndrome. Great for the joint pain, the fatigue, sometimes rashes and other conditions like lupus. Kind of like the bottom-most rung on the ladder. It's good for milder symptoms. It can be used for patients who have more severe symptoms, but generally in combination with other treatments. And most of my patients with lupus get Plaquenil because it is very helpful. And rheumatoid arthritis patients, a lot of them are on Plaquenil as well. Safe, but you have to get eye exams every 6 months to look for potential retinal deposits behind the eye, which can be managed, stopped if it's found. So Plaquenil is a good basic early treatment for a lot of patients with rheumatoid arthritis.
Well, before you continue, I have a
Yes.
question to ask you. That if a person can stand the pain, is it not better then not to take medication? Because it sounds like there's so many other possibilities that are going to emerge.
Some people think that it's better to not take medication, but most people have to take. They need to be able to function, especially, some of the older people can get by with less medication because they're not working. They don't have a place to be at 9 o'clock every day. Their lifestyle is a little bit more limited, but even seniors, they want to go out, they want to play golf, they want to go to their clubs, shopping, whatever. So it does, we don't like to see people go on to develop permanent changes and limitations when there's treatment. We always weigh the risks and the benefits of the treatment. So then after Plaquenil, we might consider adding or just giving as a single treatment, something called DMARD therapy, disease-modifying anti-rheumatic drugs, which there are several drugs in that category. The gold standard drug is methotrexate, which is a chemotherapy drug. I've written about this in this article that you have in front of you. Methotrexate is a chemo drug. It's given 1 to 10 tablets a day or by injection.
Yeah, I want to ask you about that. So
Sure.
gold was...
It used to be, yeah.
It used to be. Then they actually took gold and they injected it.
Yeah, in different forms of gold. So when I was in my training, we had a gold clinic. And they come in every week for their gold shots. And gold, most of the gold is a very thick, viscous. So when it's injected, it's not a comfortable injection, but gold was the main therapy when I was in my training in the 1980s. And then that drug became pretty much replaced, I think, for the most part by methotrexate, which is now the gold standard. So any drugs that are studied are usually compared to methotrexate, and usually the placebo arm of the study can't be, a sugar pill anymore. It's usually methotrexate because that's what we compare the new drugs to. So other than methotrexate, we've got Imuran, Arava, leflunomide. There's like a choice of different sulfasalazine, different disease-modifying drugs that can be the next rung in the ladder, the next step up after maybe anti-inflammatory steroids and Plaquenil. But using the DMARDs like methotrexate doesn't preclude the use of the other drugs as well. So there's something called combination therapy, where we combine different medications, like maybe psychiatrists will combine different antidepressants, or nephrologists will combine different blood pressure medications, because the combination may work better than individual and may actually help keep the doses down, lowering the side effects as well if you use combination as opposed to more of one drug. So those are the disease-modifying drugs. Each one has its side effect profile. Monitoring required frequently, blood work, urine, x-rays over time to make sure that the arthritis isn't progressing on a radiographic level. And then, fortunately, we have a slew of other drugs called biologic drugs, which I think I speak about. Maybe we didn't get to it in the articles yet because they're publishing a series of articles.
What are biologic?
Biologics are created drugs. They are they work at the cellular level. So remember I spoke about how rheumatoid arthritis is an inflammatory condition that has chemicals kind of being spilled by the body into the joints, and those chemicals recruit more inflammatory cells, which make more chemicals. So it's really important to stop this cascade. So these biologic agents are basically produced to intervene in this process, this inflammatory process, to block the production of antibodies, or if the antibodies are being produced, block where they attach on the cell. It's very complicated.
Yeah, it is. I'm listening.
And
I never heard anyone do is what you're doing. This is marvelous.
I hope
you
I'm
really
talking
are a
so
specialist.
Thank you.
I mean, I think people sitting in their homes listening who've been on some sort of a medication, and no one's ever explained this, just sitting there glued to what you're telling them, because I know a lot of my audience have been doing this a long time. It's wonderful to have you,
Thank you.
Know so much, and that you're willing to say, well, that may not be working so well. Let's try this, or that you are great. This is wonderful, really.
Yeah,
in fact,
I think
let me just tell everybody, Dr. Starkman, Dr. Hope Starkman, this is who you're listening to, and she's part of the Medical Center Affiliates, which is a group of professionals dedicated to providing the highest quality primary care services. And they do have locations all throughout Palm Beach and Broward counties. Okay, so keep going with the biologics. I love this.
So some of the earlier biologics, we have several of them now, and we have more and more of them every year. So Enbrel, Humira, Remicade, were some of the earlier anti-tumor necrosis factor, which probably doesn't mean anything to most people listening, but it's a chemical that is very involved with the inflammatory process. So those were the early TNF blockers. And over time, there's been the development of more. We have Simponi and Cimzia as more TNF blockers, which gives patients the option that if they don't respond to one or another, they have an option of trying a different one. However, some patients don't respond to anti-TNF drugs. So, of course, we have newer biologic drugs than that work on different chemicals other than TNF. We have rituximab, which is also used to treat some forms of cancers, lymphomas, breast cancer, which is a B-cell blocker. We have Actemra, which works on different chemicals. We have Orencia, which works on different chemicals. So the modern day thinking for the treatment of rheumatoid arthritis is, okay, so start at the bottom, maybe not at the bottom for some people who have really aggressive disease. Maybe those patients need to get a DMARD like methotrexate right away, or maybe even Enbrel, Humira, Remicade right away. Depends on the patient and their situation. But for those that have failed 2 anti-TNF drugs, maybe those patients might not respond to a third. So you would consider at that point one of the newer biologics that are not anti-TNF drugs.
Well, Dr. Starkman has been wonderful. I have to just share with the audience, since this is radio and not TV, she has not used notes. This is all from her head. She's just talking about all this, which you have a great memory and you have a great knowledge. I know that I can just feel there are many patients that have, really benefited from your information. So we thank you very much for coming here, knowing that you have your family at home early this morning, and that you also, I guess you may be doing spinning this morning for all I know, but
not this
morning. But thank you so much for being here with us. I've certainly learned a lot, and I know that there'll be a lot more in these articles as people read them, and I'm sure that people will be seeing you at some of the open houses.
Yes, I look forward to meeting people.
Thank you for coming.
Thank you so much.